This podcast, including any related materials, such as show notes, links, and supportive materials, is provided by Metagenics Institute, the educational arm of Metagenics, Inc., for general informational and educational purposes only. This podcast does not constitute medical advice and should not be considered a substitute for discussions between individuals and their healthcare providers. The podcast presenters' views are entirely their own and do not represent the views of Metagenics Institute, Metagenics, or any of their research partners and collaborators, collectively referred to as affiliates. Metagenics Institute and its affiliates do not endorse or recommend any specific healthcare providers, products, or other items or services that may be discussed or mentioned in this podcast. Podcast participants may receive compensation from Metagenics Institute and/or its affiliates. Metagenics products are not intended to diagnose, treat, cure, or prevent any disease.
We are in the midst of a women's health crisis. Our next guests, Dr. Leslie Stone and her daughter, nutritionist Emily Rydbom, are going to explain how we got here and what we might do about it.
We have the capacity and the ability to look at the data and say, okay, how can we, with a 10,000-foot, 360-degree view, look at each person who presents with these vulnerabilities and change their outcomes by how we manage that pregnancy time period. That is no longer, that we don't accept this concept that there's nothing to be done anymore.
Tune in to get into the details of nutrient depletion and how that can be passed on across generations, and which specific nutrients are proven to make a difference in the health of women from preconception to birth. Emily and Leslie, so delighted to be with you today. So I just want to say for a listener that we're at a hotel in Texas. Mm-hmm. I can hear the housekeeping crew kind of working outside the door and opening doors and talking. And so there's going to be a little background noise here. Yeah. It's okay. We're just going to keep going. I want to talk about the crisis we have in women's health. I feel like we're in a place right now where we have never been before. And what I love is that you two are offering a solution that's evidence-based, that cuts through so much of the noise, and that sets us up to have the best possible life. Mm. And so I want to get into the details, but first I want to start with some of the statistics that tell this story. Mm. What are they?
So preterm birth is one of the biggest drivers of health compromise in our developing children and even as adults. Even in the U.S. here, we have in Mississippi, we're at 13% of all pregnancies are delivered early, and there's only one higher place in the globe, mm-hmm. and that's in Malawi.
That's appalling. It's absolutely appalling.
Yeah. That's exactly right.
So let's take this for a moment. Preterm birth, mm-hmm. How do you define it?
There's a gradation to this, but preterm birth would be those that are 36 weeks or below. Late preterm births would be 37 and below, and the very early preterm births are those that are at 32 and below. But anyway, all of these preterm births are associated with distinct systems deficiencies that show up in the neonate, in the child, and remarkably and frighteningly as an adult.
Mm-hmm. So this is such a huge piece to understand. And I think overall in the U.S., it's something like 9.6% of births are preterm. Exactly right. So right. 1 in 10 is preterm. Mm-hmm. I just had a beloved niece that was born at 31 weeks. Mm. And I can tell you, after delivering 5,000 babies over the course of my career, I know you've delivered a ton of babies yourself. Mm-hmm. How many of you delivered?
Exactly.
Yeah, 5,000.
So I've delivered a ton of babies, and I've also witnessed their course, after being born at 24 weeks or 25 weeks or 28 weeks, 31 weeks. There's quite a bit of morbidity that's associated with preterm birth, as well as mortality. Mm-hmm. And what's amazing to me, when I put on my OBGYN hat, is that you have discerned some of the ways that we can prevent this.
I think it's important to say that as staggering as these statistics are, and as staggering as these statistics are applied even in our own well-developed, affluent country, there is a generational impact to that outcome that we have to talk about. If you are a baby who is a female, a daughter, being born preterm, then you as a mother going into your own pregnancy are more likely to deliver preterm because you were a preterm baby. And if you then bear a daughter that is preterm, then they are more likely to bear a preterm baby. And that generational impact is profound. And the stopgap here that we have found and that the data is showing that we can so profoundly impact is that if we can write that trajectory with a full-term birth within that generational line.
Exactly.
So let me repeat some of this, because what you're talking about is this transgenerational effect of preterm birth.
Yes.
So it's not just isolated to my niece.
No.
She's actually at risk when she has a baby.
She's at risk.
So this is such an important piece that we understand as clinicians how to correct some of these maybe nutrient deficiencies as well as other issues, but also for our listener to understand that there's things you can do. There's things that that you can do.
Yes.
And I want them to feel empowered around this too.
Yeah.
So, one of the things I love about your Instagram is that you're always bringing in the science.
Yeah.
And so you mentioned a New England Journal of Medicine article from 2017.
Yeah.
6 gene regions associated with preterm birth through maternal effect, blood glucose issues, as well as implantation. And, I just want to say that this is not just what you've found over the course of your careers and with filling nutrient gaps.
That's right.
It's very well proven in the literature.
Yeah. And I think it's in the individual nature that we address each woman that presents, and that we have the capacity and the ability to look at the data and say, okay, how can we, with a 10,000-foot, 360-degree view, look at each person who presents with these vulnerabilities and change their outcomes by how we manage that pregnancy time period. That is no longer that we don't accept this concept that there's nothing to be done anymore. Even just in our work together, I know Leslie and I have identified very specific nutrients that have profound impact on just this one single preterm birth outcome. Inositol, vitamin D, omega-3 fatty acids, an impressive kudos study, zinc. And then that what is empowering about this is that there seems to be redundancy in these nutrients and their function, that they return a woman to a place of function that doesn't only impact preterm birth, but it impacts whether or not they have vulnerability for pregnancy-induced hypertension or gestational diabetes.
So there's these lovely downstream effects beyond just preterm birth.
Yes.
So I want to get to the solutions in some detail in a moment. I just want to make sure we're casting a broad net. Okay. Because there's some people, I think, who are listening and thinking, well, there's no preterm birth in my family. I'm not going to worry about this. Let's go broader. So as I think back over the course of my career, I think about what are the vulnerabilities that maybe I haven't paid attention to, that I should be paying attention to with my patients. Especially, what are the iatrogenic vulnerabilities? So yes, there's the gene-environment interaction that I need to be thinking about, but there's also all the birth control pill prescriptions that I've written, and the micronutrient depletion that goes with that. There's the metformin that I prescribe for my patients with polycystic ovarian syndrome. So can we talk about that for a moment? What are some of those micronutrient deficiencies we can kind of riff together?
Sure,
And I think about especially that woman who goes on the birth control pill, like I did at 16.
Yes, in adolescence.
And not always for contraception. It might be, your periods are a little painful. Instead of going for the omega-3s, which are proven in randomized trials to reduce dysmenorrhea, they go for the birth control pill or for acne or to regulate their cycle. And this is, I think, it's probably, in my mind, the number one endocrine disruptor. But that's in some ways kind of the least of the problem. So what happens with birth control pills? What are some of the nutrient gaps?
They are nutrient depleters. That's exactly right. So the metabolism itself requires more B vitamins. So we have the riboflavin, we have the folic acid, we have the
B6, B12,
pyridoxine, B12,
zinc, vitamin C,
So
magnesium,
B6, folate, B12,
zinc,
magnesium, zinc,
vitamin C,
selenium too.
vitamin E.
C, vitamin E. I think a lot of women have no idea that they're depleted in these.
And probably most powerfully of all is that we find that there's an 80%, others have found that there's an 80% depletion in tryptophan, precursor for serotonin.
For melatonin, for sleep, for mood. Right.
80%.
In women who use birth contraceptives, after the 6-month time period, they have an 80% altered tryptophan metabolism, meaning lower tryptophan metabolism.
So this is one of the most important pathways in the body
Yes,
for
it
homeostasis,
Yes.
for mood,
Yes.
for sleep, for
Yes.
these factors that really drive what we're interested in, make us who we are, able to live out our mission and our purpose. And I feel like, I have so many patients who've had dysphoria. They've had mood issues as a result of going on the pill.
Yeah.
And don't even get me started about the elevated sex hormone binding globulin and
Exactly.
how women get robbed of testosterone and agency and confidence. Like that's another podcast probably. But I think this is so important. And maybe we could talk about metformin for a moment. I've got a list of some of the nutrient gaps, which are very similar. So with metformin, 7% reduction in folate, 14% reduction in B12, increased homocysteine as a result, depletion of CoQ10, not in everybody, but in people who have that vulnerability.
Yeah.
So we have these prescriptions that we are handing out as Western physicians. I was never taught to give full informed consent to my patients with a list of these micronutrient depletions, and yet we've known about them for a long time.
A long time.
20, 30 years.
Yeah, 1980, there's a big data mine. And that list primarily comes from a 1980 data. Fast forward to the point where that adolescent who has been taking birth control pills and has dysphoria, can't sleep, what often is the next prescribed?
Antidepressant.
Exactly.
That's right. And then fast forward again and say, now I want to get pregnant. Think about the mass nutrient depletion, the altered neurotransmitter pathway metabolism, and then you have a woman who's compromised simply because there was a decision made at 15 or 16 that didn't look at the whole picture.
So this is exactly the net I wanted to cast. I think this affects so many women, and I would say, probably 80% of our audience. Leslie, did you want to add to that?
I do, and that is, it may be drawing it too far out, but really it comes down to these metabolisms that are sitting at the center that these nutrients are driving, and the one I want to focus on is one that is supported by a gene called MTHFR that is affected in about 48% of our U.S. population. That makes it more difficult for that folic acid actually to be effective, even if we gave it to them. And so this recognition that we really also need to be thinking downstream in informing the people who are going to be who are in this reproductive age, in this just developmental age of thinking about good health. What we need to think about is even more influenced perhaps by this gene effect that we have, that we should need to know about. We need to be informed about that piece as well. Just as we don't want to neglect the information we had about nutrient deficiencies provoked by OCAs, we also want to be informed personally on provider or no provider, personally, that these effects can be you and that we can deal with them.
And this is part of the path of empowerment, I think.
That's exactly right.
Is to understand that it's not just nutrient depletions from these medications. It's also the way that the genes are interacting with some of these nutrient depletions. And even the genes on their own, just interacting with Western lifestyle.
Yes.
So now that we have a wide net, say we've got a 27-year-old woman who is thinking about getting pregnant in 3 to 6 months. What do you tell her? What are the top 2 to 3 things?
So can I actually cast an even wider net before I answer that
Yes,
question?
please.
Because there is a trend that is rapidly changing the construct of how we manage health. By 2030 in the United States, 85% of the population will be overweight or obese. And so it's not just this 27-year-old woman wants to become pregnant. We have to consider that more than likely she has a vulnerability just presenting, living and breathing in her own body every day.
Yes.
Right? And then the toxic burden that comes just from that altered body composition. Right?
This is so important because, I was taught when I went through my medical education that polycystic ovarian syndrome was the main metabolic thing I needed to be concerned about. It was the number one cause of infertility among reproductive age women, and that it was only affecting 10% of the population. Then I got into practice, and I thought, 10%? What are you talking about? It's more like 30 to 50%. Right. Like, I have so many more patients who struggle with this. With metabolic dysfunction, whether it meets criteria for polycystic ovarian syndrome or not. And it's, so I think this is a really important elephant in the room that you're bringing to the table.
Yeah. And so much of this is what are the 2 to 3 most important things? Well, I think that comes from, I answer from a place of 2 perspectives. One is from the perspective of the woman entering in, wanting that desperately, and that there's an understanding that there's a vulnerability there that we need to address, because if we address it and we address it well, then she will have a generational impact on whether or not her child has a prevalency and an increased risk of obesity. Yeah. So if we address it in this preconception time period, she is already changing the trajectory of her family's health because of the decisions that she made and just in the simple desire to want to be a mother. And can we language it that way so that she feels like she can do something about it? Yeah. I mean, yes, unequivocally. And in fact, we don't believe there's another way to do it. So I think entering into that space, the first is be willing and brave to assess the relationship that you have with yourself and how willing are you to think about this preventative component of your decisions. Because prevention isn't sexy.
It's a hard sell.
It's a hard sell, right? We are and especially I'm an old millennial, right? But I'm still a millennial. But I fall into this category as like that I want kind of instant gratification. This concept of patience is a difficult one because everything is so cause and effect right in your face, right? Everything, our phones, our watches, our environment lends itself to that.
Isn't our job as clinicians to take what we think our patients most need and to sell it to them.
And language it.
That's right.
To language it. And by sell, I mean the most sacred intention behind that.
Exactly.
So really understanding, okay, this is what I think you most need. Yeah. This is what needs to be addressed.
That's right.
And to message it in a way that really shows our conviction, but also gets their buy-in.
Right. Because altered hormone metabolism isn't just mediated by the fact that she was taking OCAs. It's also mediated by the fact that she has an altered body composition that changes the way her hormones communicate. Absolutely. Because of those increased inflammatory cytokine response from her adiposity.
And to extend that one more arm, and how she feels about that.
That's right.
Has a profound biochemical effect as well.
Yeah. Huge.
So that stress
component,
recognition, and then response. And we find, as we talk about what we're going to do, what we're going to make in these recommendations, that stress is the unsung and unrecognized piece that can be easily modified and result in less preterm births and smaller and larger babies. And
this
all the things that
this
we're
is so
looking for.
crucial, and it's a piece that I never got in medical school. And it wasn't until my 30s that I realized, wow, I can think my way into high cortisol. I can think my way. Like, my state of mind is a big driver of my insulin pathway, the insulin signal. Yeah. So I think this is such a crucial piece. Yeah. So let me say one other quick thing, quoting your Instagram.
Sure.
Because this is where I get so much of my science. So you had a study that really got my attention as we talk about things like altered insulin pathways and overweight and obesity. Yes. You had a study showing that a couple of strains of probiotics reduce the risk of gestational diabetes by 34%. What?
Right?
So can you explain this to us?
Yeah.
Explain this.
Well, I think it's important to realize too that science is starting to show us that it is no longer just the glycemic index of a food that determines how our body metabolizes proteins, fats, carbohydrates, specifically in that instance. That it is now we're starting to look at the microbiome might have a fairly large role in how we metabolize our glucose, right?
Right, exactly. Especially when you recognize that we have more cells of bacteria than we have cells of ourselves.
Right.
So who are we really, and who are we talking to when we add these nutritional and stress modification, interventions? Who are we talking to? Well, I think it might be some of those lactobacilli. I think that those are the ones we're speaking to, and we have. It also shows that perhaps one of the reasons why we have some of these epidemics of obesity is such that our own lifestyles have produced these for us. Bringing it back to the stress modification piece of it is that we know that the reproductive capabilities of bacteria are dramatically dropped if we just get frightened by something. Mm-hmm. So we can see that reproduction drops by about 50% within about 3 hours.
That's so powerful. Let's get into some detail here, because I think this is such an important point. You started this with glycemic index of foods, that it's a much bigger conversation than just what's the GI of the food that you're eating. It's also the microbiome and the gut microbiome brain axis. It's stress. I was just looking at the work of George Slavich at UCLA and social genomics, and he was talking about how it's not. We evolved this immune system to deal with physical injury. It evolved thousands and thousands of years ago. But it's not just physical injury that triggers the immune system. It's the threat of physical injury.
The perception.
The perception. And then I think about, eating low glycemic index food, but 80% of Americans eat in their car.
Right.
And not sitting, at some mountain in Oregon.
Right, resting and digesting.
Resting
in their
and digesting.
Space.
No, they're driving at high speed on the freeway
Yeah.
while they're eating a hamburger
That's
or,
right.
Even an apple.
Yeah.
And that's a setup for having this stress response while you're eating. It's a way of, decreasing the integrity of the gut lining. Creating dysbiosis. We know stress is a huge factor. Food and stress are the number 1 and number 2 when it comes to disrupting the microbiome. So I think this entire piece is so important, and we don't always realize the role of stress, especially when we're eating. So I think that's a crucial piece. So I'm going to go back to our woman who's 27, and she is coming to us because she's thinking about having a baby in 3 to 6 months. What do you want to tell her?
I know that I want to set the stage by recognizing how, no matter where she starts, we start where she is, and then we imbue her with the knowledge that she has the power in her range to modify. She has the power. There's so many things that we can shift, and there are simple things, doable things, empowering things that she can do to shift. We recognize them in 3 different ranges, and we've just discussed. We look at those nutrient sufficiencies or deficiencies. We look at their genomics, vulnerabilities, non-vulnerabilities, what are their strengths and vulnerabilities, and then this stress response. So, for example, one of the simplest solutions, if we're talking about this woman who's eating in the car, a simple solution would be to stop the car. There's
pull over to a rest stop.
There's a simple solution for this whole, and that's what this. So to start with the knowledge, the expectation that these are all modifiable. We are not set in stone. We get to take the reins and go.
And I think our job as our responsibility as clinicians is to not just identify the problem. We have to provide some version of a solution, even if that solution continues to change and is expounded upon. And so when, in the setting where I have that woman sitting in front of me at 27 years old, and she's asking, what can I possibly do? The first place that I always go to, which is in the core of her control, is her food. And so we do a complete assessment of top to bottom. What happens when you wake up? From the time you wake up to the time you go to bed, what happens? How is stress a part of that? How is your job a part of that? Do you have children? How are you sleeping? Because we know that how we sleep will dictate how we eat, which will dictate how stressed we feel, which will then dictate how we eat, which will then dictate if we can sleep. So I think food, and I can get down very specific into my specifics, but I think the biggest one is, as Americans, we do a poor job of eating colorful fruits and vegetables. So I think if I could start with the simplest thing, it's this concept of trying to eat a more diverse color palette. Because what we also know is that we can't just pick our favorite color. Like that question of what's your favorite color in kindergarten, and we say purple.
I can't just eat broccoli.
No, we have to
7 days a week.
Exactly. We have to think about how all these phytonutrients are communicating with one another inside of our bodies as well. And that's a very simple way of saying we have to diversify.
Yes.
Because if we approach food, any intervention in this myopic way, we are going to miss. I mean, we're going to look at the grain of sand when there's a whole beach, right? And so there has to be this concept of a simple application is color.
So what's the takeaway? I tell people, I want you to eat 5 colors every day. Aim for 20 to 30 species over the course of a week. Try to rotate those 5 colors. So if you missed the orange yesterday, try to get it in today.
Yeah, and I bring it back down in a little less calculated manner. It's at least one food every day from each color at one meal. Then you can, if you can do it at one meal, then we try for the second meal, and then we try for the third meal, right? And so that by the end of it, you're eating a rainbow 3 times a day.
What did you have for breakfast?
This morning, eggs and spinach.
Okay.
So hotels are amazing because they will bring you food. But I have to say, my decision about eggs and spinach was dictated by how much time I gave myself to really actually look at the menu, right? Yeah. And I knew they'd have spinach. So like, just put spinach and eggs on a plate, I'll eat it.
Spinach is a good backup when you go to hotels.
It is true.
So let's talk about omega-3s briefly. Yeah. I saw on your Instagram that you had a Cochrane review from 2018 showing, I believe it was with omega-3s, 10% reduction in preterm birth. Yes. Also 10% reduction in small babies.
That's right.
Unpack that for us.
Yeah. Well, I think it's important to say two things, that preterm birth often leads itself to a small for gestational age baby. And if we're looking at dramatic impact of both of those outcomes, they are the ones that have the longest reaching ranges for chronic disease risk as an adult, large for gestational age too, but those two seem to have a lot of correlation between disease trajectory. I think what was so impressive to me and to us, and what continues to be impressive, it is that in these simple interventions that there's profound effect. It doesn't look like 30,000 decisions you have to make in one day. It looks like one decision that you get to make in one day. And I think that's the type of science I love finding, and that's the type of science we love finding and that we want to talk about the most, because it's, can you take your fatty acids today? Can you take your omega-3 supplementation today? Because...
Did you get your omega-3s today?
Yeah.
And what's your dose?
So I take a dose of 500 milligrams of DHA and 400 milligrams of EPA.
Okay.
As a gram.
I'm a little more heavy-handed, but okay.
However,
depends on what you're aiming at.
Yeah.
For example, if we're aiming at preterm birth, we're aiming at about 600, 700 milligrams
of DHA.
DHA predominantly. Yeah.
Wasn't there also some EPA in that study?
There is. Yes, there's EPA as well. And this KUDO study specifically was the one that we were going to speak to, is that was done primarily with DHA. And it
small amounts, $126 per pregnancy, basically, resulted in a hugely significant drop in preterm birth.
Money very well spent.
Money very well
spent.
And they extrapolated that data over the preterm births that happened in the United States, and it's suspected, projected that with just that small amount of supplementation that we can decrease preterm birth costs by $6 billion.
Per year.
Okay, someone call the president, because this needs to be part of our public health policy.
Yes,
this is so essential.
Yeah, and then going back to that stress component, you can go to PubMed and you can type in preterm birth, NICU stays, and paternal maternal stress, and it's clear. The trigger of that event for those parents, and then the dynamics in their communication, their sleep, their stress response to one another, and then how those energetics affect that experience is incredible. However, at the same time, then the flip side of that is skin-to-skin contact with that newborn baby changes that altered cortisol metabolism, decreases stress hormone response. Again, a simple intervention that is readily available.
And the one we like to talk about is in the second and third trimesters, that regardless of the power of the stressor, people think of them as graded, I lose a spouse, or regardless of that level of stress that you might be experiencing, that person might be experiencing, simple touch, listening to music, movement, make a profound reduction in cortisol response. And then what that does, it translates into a neonate who has a normal 2 times a day changes in their cortisol levels. If we don't intervene in that early time period, they lose that. And we can predict that those babies are the ones who are going to go on to be anxious, depressed adults. Mm-hmm. Whereas if we put those simple, doable interventions in, we reverse it. We stop it right there.
Yeah.
These are interventions that create resilience.
That's exactly
And
right.
I think what's so powerful is you're not saying, okay, let's have the baby do a 90-minute yoga class. No. We're saying, just a little skin-on-skin time is going to help with the hypothalamic pituitary adrenal axis.
That's right. 15 minutes a day.
Yeah. And Sarah, I know how much your love and profound respect for yoga and your practice is there. I mean, don't even get us started on yoga practice. I mean, it's single sessions in pregnancy decreasing
That's right.
stress.
They're doable.
Single sessions.
Doable.
It's a powerful tool.
Not 12-week programs,
Right.
one time. I think this is a resounding message that just needs to be yelled from the rooftops. This is how quickly can you affect your child's health? 15 minutes. 1-5. How quickly can you turn on and off the genes that promote inflammation or decrease inflammation? 6 hours of anything you eat.
So both of you gave talks, and I still remember the slide where you talked about how food can change the expression of your genes inside of 6 hours.
And that example was given with essential fats,
Yep.
as an example,
Yeah.
in comparing it to those that are non-essential, the saturated fats. And that was the enzymes changed within 6 hours.
Yeah, and so
6
it's
hours,
all-
people.
right.
So that's a doable thing, isn't it? That doesn't
Yes.
mean that you get to ding yourself and wallow in guilt. It's because, oh no, I can do something about this. If I've done something 6 hours ago, I can rectify it in another 6 hours.
Right. So this
It gives you
concept of
really-
cheating or falling off the wagon or
It's like-
blowing it just that flies out the window, goes dust yourself up, stand back up, try again.
Because here we go.
Because your body is ready to try
and
again.
willing.
Yeah.
And willing.
Yeah.
That's the piece, is that, you ask, what do we do? What do we recommend? Well, I think the first recommendation and recognition is that we try to find people where they are, and then we ask them to do one thing. We don't tell them what not to do. We ask them to do one thing.
Yeah.
And with that one thing, their eyes will be open to the next one thing. They'll be empowered to do the next one thing.
Yeah.
And these are additive. It turns out, because of data like that, we know that it's not so much those negatives, it's the empowerment of the good things that you're doing.
Do you want to talk about the mouse study where they
The raspberry
the
study?
raspberry. I'm going to call it should be called the raspberry.
The raspberry study.
study.
It comes out of OSU, at Oregon State University. And what they did is they fed mice, I realize we're not mice, but mice, high glycemic index foods. Same diet, two sets of mice. They fed red, ripe raspberries, to one group. And they had distinctly different insulin responses just by putting in the raspberries, even with the high glycemic diet.
Such a simple intervention. The addition of raspberries, the addition of a phytonutrient that's going to change these signaling pathways.
That's exactly it.
So I love how this is, kind of a simple way in. The other, I just want to honor you, Leslie, because part of the subtext that I hear with meeting people where they are, getting so clear about what the interventions are. It's not a list of 17 things that you want people to do. It's, let's start where it makes the most sense for you, where you're going to feel success. And then maybe once you have the success with adding the raspberries and adding the omega-3s, we then could go on to another 3 things. Mm-hmm. So I just want to make sure I honor you for that. So let's finish with the 4 birth phenotypes. And maybe first, what is a phenotype? How is it different than a genotype?
So this gets us back to, I think, what drove us to begin with, and that is the frightening changes in our health status as adults, all the way through. And so we realized that these were integrally embedded in the outcomes of our babies. How are they doing? Are they too big? Are they too small? Are they too early? Are they too stressed? And so what's a phenotype? It's the expression, it's the result of all these different variables, and it's what you look like at the end of all those variables. Mm-hmm. And so if you end up too big, that's the phenotype. It turns out that those 4 birth phenotypes are the ones that predict our resiliency or our disease. And the reason why we focus on those is they are also modifiable, right? There's something we can do about all of those. The other 2 places that we focus are on 2 maternal expressions, hypertension in pregnancy and diabetes in pregnancy, because those inform whether that baby is more or less likely to be too big or too small or too early or too stressed. Mm-hmm. So it really is the impact on those 4 outcomes, those neonatal outcomes.
So let's define those super briefly, and we'll put more into the show notes. So too small is less than 2,500 grams. Okay.
That's exactly right. Mm-hmm. Or another definition of that would be 10th percentile of your ethnic group. So too small would be the lowest 10th percentile.
Too big, greater than 4,000.
That's right. Mm-hmm. Or the top 10th percentile. Mm-hmm.
Yeah. So the extremes.
That's exactly right.
Mm-hmm. And it's a spectrum, right? It's not like an on-off switch that happens at 2,501 grams.
That's exactly right. And it certainly depends on that ethnicity piece of it, the within the family sorts of things. There's such a thing as a constitutionally large baby or a constitutionally small baby too. Meaning, your parents were this big, and so why wouldn't your baby be this big too, right? Mm-hmm. So
the phenotype that we've kind of coined or tried to encapsulate the best is this concept of a stress dysregulation phenotype, which is not, people go, what are you talking about?
We sort of coined that term, it's true.
Yeah, and so what we mean to say is we need to take into account the story of the mother's stress response and whether that lends itself toward anxiety, depression. We take into account her backstory of her ACEs score, because what we now know is 60% of the United States have an ACEs score that is high.
Yes, 4 or higher.
Right?
Yes,
That's right.
So, so you can define this dysregulated stress phenotype with ACEs. Mm-hmm. How else do you define it? Do you measure cortisol levels? Do you look at heart rate variability?
So, no, we don't measure cortisol levels. However, we have the capacity with plethysmography to measure heart rate variability, and we do use that on some of our pregnant women. We go mainly into a space of symptoms. Mm-hmm. We definitely go into complications, challenges with their mood. So mood disruption is a big part of what we measure, and whether or not you can measure mood disruption is a conversation.
There's surveys,
right? That's right. That's right.
Scales.
We can mood scales, so on and so forth, and then we actively engage that stress response in that mom and try to figure out how we can mediate that. Whether that is through lifestyle intervention, whether that is through more intense interventions such as counseling, or we looked for the resources that best suit that mother in her environment at that time. Yeah. Because again, going back to the laundry list of giving somebody 20 things to do is asking them to fail.
Yeah, it's defeating.
That's right. That's right.
So, final messages of empowerment or hope. What's the one thing you want our listener to go away with?
Is that hope is our most powerful piece of this. If I can leave people with that idea that we used to say, oh, you're stuck where you are, the answer is that is entirely wrong. Entirely wrong. Yeah. We couldn't be more powerful in being able to influence this. And the most powerful time for us to influence it is before we get to before we get to reproduction. And so it has the benefits of, yes, ending up with great babies, great, wonderful human beings.
I agree.
But it also means that your health is impacted, and everyone around you is an example. And so it is a feed-forward process that couldn't be better, that starts with doability. And so that is where I would like to come home, is that this is doable.
Yeah.
It is innately doable for all people. And so we just don't want to get too complicated about it, because we don't need to. The power is in that just one thing.
Yeah. And I think in order to create that change, a core principle of how we have arrived at this point is to say, health is so much more about what you add than what you take away.
Yes.
And so this concept of loss because I can't have something or can't do that, we just don't even enter that space, and we go, here's something you can do. And that is actually truly how we approach an addictive behavior. Okay, so we don't take away the addiction. We say, what else can we do to empower you, make you feel better, so that you can imagine maybe feeling better?
So then you can let go
right.
of that addiction.
Yeah.
That's exactly
and so
right.
it is so much more about what is added to your life than what is taken away.
That's right.
And that my encouragement and challenge is always to look for the quality of the food going into your mouth, the quality of the relationships, the quality of the sleep, rather than the quantity. We have become skewed in our society and how that conversation impacts us, that it must rest in this quality space more than the quantity component.
Yeah.
Yeah.
So our quote, I think, that we go to all the time is, start where we are. Do what we can. And keep doing it.
Yeah.
Leslie and Emily, I want to thank you for being with me today. I can tell you that I feel the benevolence of the work that you do in the world. I think it's so impactful and so important, and I really want to make sure we get this message out. I also can feel my epigenome is upgraded by being with you. So thank you.
We are honored. We are honored to be able to even sit here and talk about this. I was describing it is of the utmost delight that I even get to open my mouth to talk about this. So thank you. Yeah, so thank you.
Thank you for being with us for this episode of The Practice. You'll find extensive show notes, including links and supportive materials, over at thepracticepodcast.tv. While you're there, explore other topics and use the Ask and Answer button to ask your burning questions and give your insights about the topic. After all, the future of medicine lies in dialogue, not dogma. Let's transform medicine together by connecting on Twitter, Instagram, and Facebook. You'll find all the links at thepracticepodcast.tv. This podcast, including any related materials such as show notes, links, and supportive materials, is provided by Metagenics Institute, the educational arm of Metagenics, Inc., for general informational and educational purposes only. This podcast does not constitute medical advice and should not be considered a substitute for discussions between individuals and their healthcare providers. This podcast does not create a doctor-patient relationship and should not be considered a substitute for the independent professional judgment of any physician or healthcare professional regarding the appropriate course of action for a particular patient or individual. Metagenics does not make any guarantees regarding the accuracy, completeness, or usefulness of this podcast for any particular purpose. Listeners may use this podcast at their own risk, and patients should not disregard or delay seeking advice from their healthcare providers based on the content of this podcast. Participation through the Ask and Answer button is optional, and no participant should feel obligated to provide personal details, including about any diagnosis, symptoms, or other health-related information. Neither Metagenics Institute nor any of its affiliates seek this information, and it is not necessary to participate in the dialogue regarding this podcast. The podcast presenters' views are entirely their own and do not represent the views of Metagenics Institute, Metagenics, or any of its research partners and collaborators, collectively referred to as affiliates. Metagenics Institute and its affiliates do not endorse or recommend any specific healthcare providers, products, or other items or services that may be discussed or mentioned in this podcast. Podcast participants may receive compensation from Metagenics Institute and/or its affiliates. Listening to this podcast does not obligate you to purchase, use, recommend, or prescribe any Metagenics or Metagenics Institute products or services, including their educational materials. Metagenics products are not intended to diagnose, treat, cure, or prevent any disease. Unless approved by Metagenics Institute, this podcast must be used only for personal, non-commercial purposes. This podcast has no independent economic value and is intended to comply with all applicable laws. It may be rescinded, revoked, or amended at any time without notice. Listeners who are patients should talk to their healthcare providers if they have any questions regarding the content discussed in this podcast. Listeners who are healthcare professionals may obtain more information by visiting metagenicsinstitute.com, calling 888-690-8500, or emailing med@metagenicsinstitute.com.